Hello, ladies and gentlemen, and thank you for waiting. Welcome to today's call, VHQC Virginia and Maryland, Building a Culture of Safety, Strategic Approaches to Infection Prevention. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Deborah Smith. Deborah, the floor is yours.
Thank you, Erin. Hello, and welcome to the kickoff webinar for the Maryland and Virginia HAI Improvement Network. My name is Deb Smith, and I'll be facilitating the webinar today. I'm the infection preventionist for VHQC, who will be working with you on the HAI improvement projects, and I'll be reaching out after this webinar to offer any further explanation about the HAI Improvement Network and answer any questions you may have about joining VHQC to decrease all HAIs. We're excited to kick off our Maryland-Virginia HAI Improvement Network. I'd like this session to be interactive, so please participate by posting your questions and comments in the chat box. As you can see, you can find the chat box by clicking on the chat icon at the upper right-hand side of your screen. Amy Lentz will be facilitating the chat box questions and comments during the webinar. We will also open up the lines at the end of the webinar for questions. I'll begin our session with a brief overview of VHQC and the Quality Improvement Organization, or QIO, program structure. We have a provider joining us, and they will share their recent CDIF quality improvement success. Finally, I will be sharing information about our new quality improvement initiative, the Maryland-Virginia HAI Improvement Network. So let's get started with a question. Can you please post the first polling question? So in order to get an idea of our audience today, how many of you have previously worked with a QIO? While you're answering the question, I'd like to introduce our new state program directors. Sheila McLean is the director for Maryland and will be leading the initiatives there, while Marcy Gillespie will serve as the director for Virginia. We're also adding several new team members to support providers in Maryland. Both Sheila and Marcy are on the webinar today and available to answer any questions you may have specific to the overall programs in Maryland and Virginia. Dr. Sally Cook, Chief Medical Officer for VHQC, is also on the line and available for questions. So the polling should be done, and it looks like quite a few of you have worked with a QIO before. So we hope you'll continue this work with VHQC, and that the rest of you who have not previously worked with a QIO will see the benefits of working with us. Next slide. VHQC is a private, not-for-profit healthcare consulting company and has served for the QIO for the state of Virginia since 1984. We're excited about the opportunity to now serve as the QIO for both Maryland and Virginia. VHQC consultants come from a wide range of healthcare backgrounds. Our experienced team includes former hospital executives, nursing home administrator, physician practice managers, nurses, health information managers, health communicators, physicians, and pharmacists. Building on our QIO experience in electronic health record adoption, or EHR, we also serve as Virginia's statewide Regional IT Extension Center, known as Virginia IT Program, or VHIT. VHQC has also led two of the Centers for Medicaid and Medicare Services, QIO, National Coordinating Centers. These coordinating centers supported all of the state's QIO programs and served to strengthen our understanding of provider needs and supporting education across multiple states. Beginning in August 1st, CMS implemented changes to the quality improvement programs. To eliminate any potential conflicts of interest, CMS separated Medicare case review activities from the quality improvement work. So case review activities are now performed by beneficiary and family care centers, QIOs, or VHQC QIOs. There's two national contractors that operate as the VHQC QIOs. K-Pro serves as the VHQC QIO for Maryland and Virginia, and we've listed K-Pro's contact information for you here for your reference. The separation for case review from quality improvement work led to the creation of Quality Innovation Networks. Quality Innovation Networks, or QIOs, like VHQC, will place a singular focus on quality improvement. 14 QIOs will support work across the country. QIOs are regional and cover 2 to 6 states. As we've shared, VHQC is the QIO for Maryland and Virginia. This QIO contract period has also been extended from 3 years to 5 years. As the QIO, VHQC will champion local-level results-oriented change. These efforts will be driven by data, and we will actively engage patients, families, and other partners. We'll also use proactive, innovative, and sustainable quality improvement methods to accomplish these goals. VHQC staff will facilitate learning and action networks using the All-Teach, All-Learn method. Everyone participating will share best practices and lessons learned. We learn best from each other, and we solidify that learning when we teach someone else. VHQC will teach and advise as technical experts with VHQC staff who are well-trained in many different areas of quality improvement, and they will share their expertise with participating hospitals. We'll communicate effectively because communication is the key to effective quality improvement change. This communication begins at the bedside with the patient and impacts all levels of patient care, staff engagement, and effective leadership. The QINs will focus on improving care across these 3 key aims: better health, better care, lower cost. CMS has been supporting these goals for some time now, so this probably looks very familiar to you. All of our initiatives fall within these 3 categories, and as you can see, reducing HAIs falls under better care, along with reducing healthcare-acquired conditions in nursing homes and care coordination to reduce readmissions and adverse drug events. In the last QIO work that ended this past July of 2014, VHQC made great strides in reducing the aggregate HAI rates of our participating hospitals. We used the goal of 1.0 for the Standardized Infection Ratio, or SIR, which is a risk-adjusted national benchmark. The CLABSI SIR was reduced to 0.37, the CLAUDI SIR reduced to 0.91, and the CDIF SIR to 1.15. So as you can see, our participating hospitals exceeded the goal in 2 out of 3 of the targeted HAIs. VHQC participating hospitals also began work on antimicrobial stewardship. This work will be expanded upon during the next 5 years. I would now like to introduce to you an infection preventionist from one of our hospitals who has been working with VHQC to reduce C. diff over the last 3 years. Augusta Medical Center in Fishersville, Virginia, was able to attain a 21% relative improvement rate in their C. diff rates compared to the project baseline. And as we all know, reducing C. diff is one of our most challenging projects. I will now turn the program over to Tracy Sensasio, one of the infection preventionists for Augusta Medical Center. So Tracy, the floor is yours.
Thank you, Deb. Hello, everyone, and thank you for having me today. It's quite an honor to speak to you all about our challenges with C. diff and our affiliation with the VHQC. I'm on your left with the fuzzy hair. My colleague Glenn Evers is on your right with that beautiful smile. We are located in the beautiful Shenandoah Valley of Virginia. We are a community-owned hospital, one of just a few left in Virginia. So resources, like the VHQC is so important to our facility to be able to, reach out and collaborate with so many other wonderful facilities. Amy, if you could advance the next slide, please. Our medical center, our Augusta Health Medical Center, is a wide system. We are a community-owned practice facility, but we have Augusta Medical Group, which is a very large physician-based group. We have probably 20 outpatient physician practices. We are now an accountable care organization, our Augusta Care Partners. We have a fitness center, we have a child care center, we have a cancer center, and we just built a new heart and vascular center. So even though we are a community-owned hospital, we are a very large health system. Next slide, please. When you look at our rates, you see the rates in green were our 2013 rates. In August of 2013, we took a giant jump with our C. diff infections lab ID rates. And it was odd to us because it was summer. Why are we having these infections? We didn't have a lot of folks in the hospital. We weren't experiencing pneumonias and the flu like we do during that time of year. So that kind of brought VHQC to us and helped us start to look at our processes and see exactly what we were doing that were causing our rates to be so high. And if you look at the purple line, you can see that this is for 2014. We had indeed made great strides in keeping our rates down. Next slide, please. This is our quarterly adjusted SIR, and if you'll look at the facility is in blue. And we're not where we want to be yet. We still at times have providers that are ordering tests inappropriately, or specimens that are delayed in collection 3 or 4 days into the admission. But we've definitely come such a long, long way from 2013. Next, please. So some of our barriers were the knowledge deficit regarding our C. difficile rates. We have a heavy burden of C. difficile in our community. There are 5 long-term care facilities who feed into our hospital. We're very close to University of Virginia Hospital Tertiary Center. We share a lot of those patients. To our north, we have Rockingham Memorial and Centera. Rockingham Memorial, excuse me. It's hard to remember to say it that way. And so we share a lot of patients in this area. So there was a pretty heavy burden of C. difficile here. So we had some knowledge deficits regarding our rates. Nurses were sometimes practicing outside of the scope of their nursing practice, and when I say that, they would order a C. difficile test without the physician's knowledge. So there were some tests that were being ordered. Patient was having diarrhea. They were doing the right thing in their mind, but they never followed it up with an order. So the physician sometimes never even knew this test was setting out there. Isolation status for us had no real special meaning. Until recently, we were doing active surveillance with MRSA and VRE. So on any given day, we'd have 30 or 40 patients in our hospital in isolation. So it really wasn't given the intended special meaning that it needs. Kind of normal, everyday work. We had so many people in isolation. So we needed to tighten that up. We did have some non-compliance with our personal protective equipment. We have an on-site laundry, which presented some challenges there, and we couldn't get it all disposable just for the cost. But we've been working with our provider to get some different gowns that do not tie in the back, that would alleviate some of the problems. Most of the time it was folks were not tying their gowns appropriately. And we had ill-fitting gowns because we have an on-site laundry, we only had one size. So we had to work on that. Our hand hygiene, I'm sad to say, is at 59%. We use the Joint Commission Targeted Solutions tool, and we are having a mock survey right now, actually, and they were quite impressed. So I would say, if anybody wants to look at that online, it's a great tool to use to accurately capture your hand hygiene. But our compliance rate is just dismal, and we've sort of plateaued out at 59%, so we know we have lots of opportunities for improvement there. There was a lack of ownership and accountability for preventing infections, and you just need to look at your hand hygiene to realize that that's not, folks were not really taking ownership of how important it is to wash our hands. And we also were seeing a problem with shared equipment, Dynamaps, mobile blood pressure devices going from room to room and going in isolation rooms, when there was clearly patient-specific equipment in the rooms. There's just some knowledge deficits there. So lots of barriers. Next slide, please. So thank goodness the VHQC swooped in. As I've always teased Deb, she was the light at the end of our very dark tunnel. They visited us in December of 2013. We met with infection prevention, obviously, and administrative leadership to really start to highlight, hey, you guys have a problem here, and it was wonderful. So, VHQC offered the assistance, the support, and guidance, and gave us suggestions on how we could go about lowering our rates. We educated our nursing staff and our physicians. It went to the very top executive level in our hospital. We had still a few physicians who were testing for cure, and we just had somebody last week we had to go talk to again. So there's some knowledge deficits there, but we were having physicians testing for cure to just remove patients off of isolation. Our nurses trying to test for cure, same thing, to get them off of isolation while they were in the hospital. We're really working hard on our hand hygiene. We've have embraced the provider-based clinics. They are now working through the Joint Commission Targeted Solutions tool. They're seeing some improvement in their areas. We still have not been able to move that needle in inpatient yet, so we're really working hard with that and working with nursing particularly to focus our attention there. We've worked extremely closely with our environmental service leadership. We monitor terminal cleaning. We go out together as a team, looking at rooms, looking at opportunities for improvement. That's been a wonderful collaborative relationship. We are isolating now as soon as a test is ordered or anytime there's any GI sort of a suspected illness. That was not happening before. We were waiting a lot often for the test result. We have changed our gowns. We're going to a 360-degree coverage isolation gown. That should come to us in November. That was quite a hurdle to get over. We provide educational flyers to staff and, constantly bringing this up at medical staff meetings. We're usually on the agenda to update folks on where we are with our C. difficile. And the medical staff has been extremely receptive and supportive of that. Next slide, please. So for us, partnering with the VHQC regarding our opportunities for improvement really raised the awareness at the leadership level and started to drive the change that we needed to start seeing our rates come down. And I have absolutely no doubt in my mind that had we not had the visit in December of 2013, we would not have made the gains we have made. We know as a facility we still have a way to go. We had 3 in September. I'm so depressed, I can't stand it. But we know that the VHQC is always ready to support us with our efforts with educational material, assistance, rounding with us in the hospital, whatever we need. They are always there to support us. It really does take all of us to make a difference in patient safety and to reduce infections. And that's why I think this collaborative is so important, because we don't feel in our world, Glenn and I don't feel like we are alone. Not only do we have access to wonderful organizations like the VHQC, we have access to all of you who are on this call, that we can share information, increase our transparency, and all work together. You may have something that's working for you that we don't know about and haven't tried yet. So it's just a wonderful venue to share and for everyone to be able to impact patient safety and really make a difference. Next slide, I think that might be all for me. Yep. And if you have any questions or if you just want to contact us, feel free. There's our my contact information, and I look forward to hopefully working with a lot of you.
Thank you, Tracy. That was awesome. So I would like to take a few minutes now to see if anyone has any questions or comments for Tracy about Augusta's barriers or their successes. Can you open the lines for comments and questions now?
The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7.
And Amy, is there any questions or comments in the chat?
Yes, I believe this question is for Tracy. There's a question in the chat. She was curious, what was the hand hygiene website?
Oh, thank you. Oh, wonderful. If you go to the jointcommission.org, and it will be under TST, our Targeted Solutions Tool, and you register your facility, and there's all sorts of training materials, posters, stickers, and what was really nice when our Joint Commission person was here, that they're still here today actually, they really encouraged hospitals to use that because the tools it's all free, and it really gives an accurate reflection. Everyone watches a video, we do the hand hygiene observations exactly the same. It gives you very solid data. And one of the things she did mention to us was that when hospitals say they're at 90% or above, it always raises their eyebrows to the Joint Commission. They said, there's no way you can be that. So she applauded us for our honesty at 59%, which, made me feel like I wanted to crawl under the table. But still, it's a wonderful tool. So jointcommission.org, Target Solutions tool.
Thank you, Tracy. Erin, are there any questions on the line?
Yes, we have a question on the line from Robert Yakubik. Robert?
Hi, Tracy.
Hi, Robert.
Very nice presentation.
Thank you.
We were just curious, do you have an antibiotic stewardship program in place?
We have a very loose, it's a wonderful question, Robert, and thank you for asking it. We have, because that's what we hope to work, again, with the VHQC with that. We have a very loosely based antimicrobial stewardship right now. We have PharmDs, excellent PharmDs, who are watching our antibiotic uses, having those conversations with the physicians. Gwen and I are watching those. But we don't have it reined in tightly enough yet that we can really feel like we have a handle on that. So that's the next big step for us for 2015 is to really work on developing a distinct antimicrobial stewardship program that is workable for our hospital. Great question, and so important and so timely.
We're in the same place. Thank you very much.
You're welcome.
Again, if you do have a question, please press 7.
Were there any other questions on the line, or Amy, anything else in the chat?
No further questions in the chat. Octavia did comment that she appreciates Tracy's transparency.
Thank you. Thank you, Octavia. I appreciate that very much. It's not always easy, but it's how we all get better together.
All right. Well, I think we'll move on. If you do have any more questions for Tracy, you can type them in the chat. There's a possibility, since she shared with you that they're doing a mock survey, that she may have to get off the call early, but we will get in touch with her and get the answers out to everyone who's on the webinar if that happens. So thanks again, Tracy.
Thank you, Deb. Thank you for asking me. It was a pleasure.
Thanks. So by achieving this aim that's here, promote a culture of safety by decreasing the occurrence of healthcare-associated infections within healthcare institutions in Maryland and Virginia, the Maryland and Virginia HAI Improvement Network will continue the progress made over the last 3 years. Decreasing HAIs has been shown to increase the quality of beneficiary care, save lives, and decrease healthcare expenditures. The time frame for this new network is 2014 to 2019. We're currently recruiting hospitals across both Maryland and Virginia. Recruited hospitals will benefit from training and resources based on proven evidence-based best practices. The HAI Improvement Network will provide strategies and educations that can be applied to facility-specific improvement opportunities. Strategies will be based on best practices shared by high-performing hospitals nationwide and statewide. The goals over these next 5 years will be to continue the reduction of central line-associated bloodstream infections, or CLABSIs, catheter-associated urinary tract infections, or CLADIs, C. difficile infections, or CDI, and we're going to add VAE, ventilator-associated events, by 2016. Our participating hospitals will be advancing effective antimicrobial stewardship throughout their institutions and into the community by partnering with key community stakeholders and organizations. We'll be working on HAI prevention and quality improvement projects in the hospitals using successful QI protocols such as CUSP and TEAM steps, which I know a number of you have already been involved with. And of course, this work is all to provide better, safer, patient and family-centered care. So in order to accomplish this, we'll be working harder to include patients, families, and their families in the prevention of HAIs. So just real quick, you can type into the chat, how many of your hospitals already are including patients and families as advisors for committees, councils, educational development, or any other aspect of their health care? If you just share that with us in chat, that would be awesome. Next slide. So in order to obtain improvement to reduce HAIs, we first need to build a culture of safety where the whole team, from the patients and families to the healthcare staff to the hospital administration and up through the board of directors, must be informed and involved in quality improvement efforts. We need to be able to create a culture that embraces full disclosure of data and the barriers to success you've encountered in order to recognize and address the resource gaps. VHQC can assist these efforts through consultation and coaching by qualified improvement experts. VHQC will be conducting one-on-one coaching calls and group teleconferences, workshops, and webinars where participating hospitals can share their best practices and discuss what works and what didn't work for their programs. VHQC will identify peer mentors and link hospitals together to develop protocols based on proven infection prevention practices. These peer mentors come from a variety of healthcare backgrounds in the hospital and other healthcare facilities in the community. Some of these backgrounds are pharmacy, infection prevention, laboratory experts, quality improvement experts, and physicians, just to name a few. VHQC also has access to state and national experts who can assist with the development of infection prevention programs. VHQC has developed and shared many infection prevention tools during previous infection prevention work, and many of you who have been with us before have used these tools. We'll continue to assist hospitals with the development of new tools in the fight to reduce HAIs. So how does your hospital benefit from participating in the Maryland and Virginia HAI Improvement Network? First of all, this facility-specific HAI improvement assistance comes at no cost to your facility. Your hospital will have immediate access to all the tools and resources developed and offered by VHQC through an online community. Because VHQC is a part of a national HAI improvement network, your hospital will be linked with state and national quality improvement experts and have access to the most up-to-date strategies and best practices in infection prevention. VHQC has the expertise to assist your hospital perform a system assessment in order to generate a quality improvement plan of action. And VHQC can offer support for your hospital's infection prevention program. Another benefit to participating with VHQC's Maryland, Virginia HAI Improvement Network is that all the work and projects you will be working on with VHQC will align with other improvement networks that you may already be working with. There'll be no duplication of work that you're already doing. So as you can see here, all of these national CUSP, antimicrobial stewardship, team steps, NHSN, your state health department, all of these goals are our goals. So what's expected from you when you join the Maryland, Virginia HAI Improvement Network? If you haven't already formed an interdisciplinary team for infection prevention and antimicrobial stewardship, you'll be asked to. You'll be asked to participate in HAI Improvement Network activities. And these activities will include teleconferences, workshops, and webinars developed by assessing the needs of the participating hospitals. You'll utilize a data-driven and proactive approach to infection prevention. HAI data will be monitored and compared to available state and national data in order to identify opportunities for improvement. You'll grant VHQC access to NHSN data and submit that data within 30 days of the end of each month. Timely data submission will allow VHQC to play an active, real-time role in quality improvement. You'll develop and apply strategies for decreasing HAIs. These strategies will be developed with the assistance of VHQC and the collective expertise of all the participating hospitals in the HAI Improvement Network. You'll actively share the best practices from other facilities. Working as a team of hospitals in the HAI Improvement Network means that all hospitals benefit from your successful prevention strategies, and you will benefit from other hospitals' successes. You'll identify and involve patient and family advocates. Ultimately, the patient will benefit the most from our combined efforts to reduce HAIs. We will be developing a network of patients and family advisors and advocates to assist us to develop practice from the patient and family perspective. So what can you expect from VHQC? You'll receive monthly data reports specific to your hospital and quarterly reports on the overall HAI Improvement Network data. You'll have access to a review of all your HAIs using the most up-to-date NHSN definitions. It's a second set of eyes, so to speak. VHQC will continue to develop and share HAI prevention tools based on hospital requests and needs. We will also identify and share successful resources and tools developed by your fellow participating HAI Improvement Network hospitals. VHQC will hold workshops and meetings with the objective of bringing together a collaborative group of stakeholders to work on identified infection prevention barriers. And VHQC will seek out and connect you to the community organizations who can support your hospital's prevention efforts. Next slide. And it's very simple to join the VHQC Maryland and Virginia HAI Improvement Network. You received the commitment form and talking points along with the presentation slides for today's webinar. So you can use the slides and the talking points to review the benefits of joining the HAI Improvement Network. Then please sign the commitment form and have a member of the hospital's board of directors sign the form also and return it to VHQC. After signing the form, the next step will be to grant VHQC access to your hospital's NHSN data, and we'll begin the journey of decreasing and preventing HAIs over the next 5 years. So before we conclude this session and take questions and comments, I would like to ask everyone to please take the time to fill out an evaluation form once it's posted. So can we post the webinar evaluation now and then open up the lines for questions, Erin? Remember that both the Maryland and Virginia program directors and Dr. Cook are also on the line to address your questions and comments. And Amy will be letting us know what questions and comments are in the chat box.
And to ask a question on the line, please press the number 7 on your telephone keypad.
So, Amy, are there any questions in chat at this time?
Currently, there are no questions in chat.
Looks like a number of you are using patients and families in your infection prevention work. So we'll be calling on you to assist us.
Again, to ask a question, please press 7. There are no questions in the queue at this time.
Okay, and Amy, is there any questions in chat?
No, there are no questions.
And no questions for the Maryland or Virginia program directors. Well, if that is...
I'm sorry, Deb. This is Tracy. I just have a comment. I really appreciate the opportunity to work with our colleagues in Maryland. I think that's going to be an exciting partnership.
Yes, we're looking forward to that also. Thanks for bringing that up, Tracy. Well, if there are no further comments or questions, you all are going to get some of your time back for the day, and I know that's very valuable. So thank you for taking this time to attend the Maryland and Virginia HAI Kickoff webinar. I'd like to invite all of you to join with the VHQC team to improve and or enhance your efforts to reduce HAIs. Please feel free to contact me. Next slide, Amy. My contact information is here, so contact me with any questions or comments that you have, or if you need help in joining the Improvement Network. And please take the time to fill out the questionnaire here that's posted. All right, thank you very much, and have a great afternoon.
This does conclude today's teleconference. You may now disconnect.